Thank you, Mohan, for that kind introduction. Chairpersons, ladies and gentlemen, good afternoon. I'm sure everybody agrees that obesity today is one of the most pressing global health problems. It's not only daunting in the global prevalence that it carries, but also the complexity of management of obesity. And to understand the nuances of this obesity management, we welcome you to this symposium, ushering in a new era of obesity management. We are honored to have Professor Michael Nauck, who is a pioneer in incretin-based therapy research, especially research, and Dr. Mohan, whom I thank along with Lily for inviting me to you to speak this afternoon. So we have two talks here. The first one will be by me, which is Surmounting Obesity with Tirzepatide, and the second will be Redefining Weight Loss, Tirzepatide versus Semaglutide by Dr. Mohan. And then we'll have a Q&A. This program is sponsored by Lily, and both the speakers are contracted and speaking for Lily. We remind you that the topics covered will only be, the questions related to these topics will only be answered, and other topics could be discussed with speakers one-to-one after the meeting. Some housekeeping rules: please don't take pictures, please don't take screenshots of slides, and don't post anything on social media. Well, what does surmounting mean? Surmounting means really to conquer or to overcome an obstacle, and how aptly this title of the Surmount trial was done. Surmounting Obesity with Tirzepatide. And I'm going to call it TZP so that it saves time. Now, Tirzepatide or TZP has really been a groundbreaking therapy for the management of obesity ever since it's been introduced. These are my disclosures. It is a novel mechanism of action. Now, you will remember that Lilly introduced the first GLP-1, that was Byetta, in 2007 in India, and then came the once weekly dulaglutide in 2014. That was another first for them, and this is another first for them by really unlocking the power of the forgotten incretin, that was GIP. And they stitched together an incretin partnership between GIP and GLP-1 and created this peptide, which has complementary benefits on glycemia and weight. Now, TZP has really a novel mechanism of action. It's a single GIP-based structural molecule. It works at both GIP and GLP-1 receptors. But let me tell you in a minute how you can set it apart from a GLP-1 like a semaglutide. So at the GIP receptor, it works exactly like the native GIP. When you go to the GLP-1, there is a problem. Because of the fatty acid side chain, there's a conformation of the GLP-1 receptor. And therefore, at the GLP-1, it preferentially stimulates the cyclic AMP, which is responsible for insulin secretion, decreased appetite, and so on. But it minimally recruits the beta-arrestin pathway, which you may have read is responsible for desensitization of receptors, causing nausea, and so on. And that is why this is called biased agonism. So you've got two mechanisms here. You've got a dual agonist in the form of GIP-GLP-1, but you've got a biased agonism because of the mechanism how it differentially works at the GLP-1 receptor. And that really sets it apart because it causes less side effects, it's more effective, has more efficacy, and so on, which we are going to show you. The mean half-life is about 5 days, enabling it once weekly, and no dose adjustments are required for renal and hepatic impairment. Now, this hormone, like the GLP-1, is secreted as you eat food. And so there is a glucose-dependent insulin secretion and a glucose-dependent glucagon secretion, in contrast to what happens with the GLP-1 where you got glucagon suppression. And this is because of a direct action on the alpha cell. It also has an insulin-dependent action on the adipose tissue via the LPL enzyme, that is the lipoprotein lipase enzyme. It helps to regulate lipolysis, lipogenesis, and this is because of the direct action on the adipocytes. Again, an action which GLP-1 doesn't do, because the adipose receptor, because the GIP receptors are present on the adipocytes. There is an insulin-dependent increase in adipose tissue blood flow, vasculature, and also some direct action on the endothelial cells. Now, at the level of the brain or the CNS, it causes food intake inhibition, satiety, anti-emetic, and some neuroprotective effects. And all of us know that through the hypothalamus and the brain stem, you get these satiety effects. Now, let me explain to you in a minute the action of GIP, how it importantly regulates lipid metabolism. It is highly expressed in human adipocytes, as I just mentioned, and when you have a postprandial condition like the one that you have just now, GIP increases both glucose and lipid uptake into the adipocytes in an insulin-dependent fashion, promoting really clearance of triglycerides and lipoproteins. So, if your GIP is working fine, this is happening. It also increases adipose tissue blood flow. I showed you a minute back in an insulin-dependent fashion, further enhancing the effect of GIP and utilization of lipids in the postprandial state. And now suppose you block this, then you will have fats deposited at ectopic sites. What happens in the fasting state? It mobilizes lipids from these adipocytes, allowing the utilization of adipose and non-adipose tissue. And what happens when you combine the GIP and GLP-1? You get greater improvements in postprandial lipid metabolism compared to a GLP-1 alone, including you get greater clearance of triglycerides, chylomicrons, and so on. It increases fatty acid oxidation, and this removal of the fat or the fatty acid oxidation, etc., improve insulin sensitivity, and that is why you have this insulin sensitizing effect via improvement in fatty metabolism. Now, what are the indications as of available in India? So, we are talking of indications in India. Is indicated for the treatment of adults with insufficiently controlled type 2 diabetes as an adjunct to diet and physical activity. That's crucial for any therapy. As monotherapy, when metformin is considered inappropriate due to intolerance or contraindications, or in addition to other medications, which I am just going to show you in the various trials that it was done. And then you have got chronic weight management. In addition to diet and physical activity, you can use this in BMIs of greater than 30 or greater than 20 in the presence of at least one other obesity related complications, which could be like hypertension, dyslipidemia, obstructive sleep apnea, a cardiovascular disease, prediabetes, or type 2 diabetes. So, these are indications as per the PI in India. Now, Lilly conducted two very robust clinical programs. The first is the SURPASS trials, and this was a comprehensive development program trying to establish the safety and efficacy of TZP across different stages of type 2 diabetes and comparing it with other medications that we use on a daily basis. So, you had the SURPASS 1 trial, which was against placebo. You had SURPASS 2, which was worse against semaglutide 1 milligram as add-on to metformin, and so on. And you can read there, this was with basal insulin versus glargine versus placebo as add-on to insulin and as add-on to oral drugs. And it was able to establish the efficacy and safety of TZP as effective anti-glycemic agent and also for effective weight loss. And then came the very effective SURMOUNT trial. I just showed you the SURMOUNT and I explained the word. And this was again a very robust clinical trial program involving over 5,800 patients. Most studies were conducted over 72 weeks. Most of them were double-blind, placebo-controlled, except one which was open-labeled. That was SURMOUNT-5, which Mohan is going to talk about. Remember that except for one, that is SURMOUNT-2, all people in this program did not have type 2 diabetes. So we were studying obesity in this robust clinical program. And I'm going to speak to you about SURMOUNT-1 and SURMOUNT-4. And these were, again, very important programs conducted in large number of patients. Let me talk to you about SURMOUNT-1. Now, SURMOUNT-1 really tried to investigate the efficacy of 5 milligram, 10 milligram, and 15 milligram versus placebo in adults with overweight or obesity with complications. And I already explained the complications, which could be hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease, excluding diabetes. So there were no diabetics here. And after a 2-week screening program, these patients received escalating doses. So one group received placebo, one group received the maximum dose 5 milligram, then 10 milligram and 15 milligram. And this was a multi-center randomized double placebo-controlled trial across 119 sites in 9 countries. And what were the co-primary events? Percentage change in weight from baseline at week 72 and percentage of population weight reduction of greater than 5% at week 72 again. And remember, this was on the background of diet and physical activity, reduced diet in calories by 500 and physical activity. And what did it show? It showed very clearly that there was a 16% average weight reduction with 5 milligram. That was the lowest dose of TZP used in this trial at 72 weeks. And the graphs started separating as early as 4 weeks. And with the maximal doses at 15 milligrams, you had a weight loss of 22.5%. Again, and the mean baseline weight was 104 kg. And you can see how early and sustained weight loss it had. Now, if you look at this here, you will find that almost 1/3 of people who were on 5 milligram lost more than 20% weight. And 60% people on 15 milligram lost more than 20% weight. But even at 5 milligram, there was considerable weight loss, almost 80 to 90% weight loss, more than 5% on 5 milligram, 10 milligram, and 15 milligram, showing the efficacy of this drug. It did not only reduce weight, it also reduced body composition, and the main loss was from fat mass rather than lean mass. And this was a sub-study of the SURMOUNT-1 trial using DEXA, which is a dual energy X-ray absorptiometer. So there was a greater reduction in fat mass than lean mass as compared to in composition versus placebo, and most of this fat was fat loss. It also improved cardiometabolic profile. And you can see the cardiometabolic risk factors all going down. So you have a systolic blood pressure, a diastolic blood pressure, triglycerides all going down, LDL cholesterol and HDL cholesterol going up. So it was not only reducing weight, glycemia, but was also behaving as a metabolic regulator. Mind you, if you look into the details of the study, about 40% people in this study, SURMOUNT-1, were pre-diabetics. They had excluded diabetes, but they were pre-diabetics. And after the study, they found that 95% of these people had converted from pre-diabetes to normoglycemia. Another very important message that you can have for your practice. Now, the big question that all of patients ask us as doctors, how long do I need to take this therapy? What if happens if you discontinue TZP? And that's the SURMOUNT-4 trial. Remember that by definition, obesity is a chronic, progressive, relapsing condition. So if you keep that in mind, the answer is you continue therapy, and that is what is shown here. You are comparing TZP at the maximum tolerated dose vis-a-vis placebo in patients with obesity or overweight, again no diabetes. So after 2-week screening, people are put on 2.5 milligram, 5 milligram, and then they put them to the maximal 10 to 15 milligrams. And at 36 weeks, they are randomized to receive either 10 or 15 milligrams of TZP or placebo in the background of diet and physical activity. Again, a 3 multi-center trial, double-blind, placebo-controlled, 783 patients, of which 670 were randomized. Percentage change in body weight from week 36 to week 88 was the primary endpoint. And this is the answer here. So 20.9% weight loss had occurred from week 0 to 36 in people who received TZP 10 or 15 milligram, and if they continued, there was another 6% weight loss. So 26% weight loss had occurred between week 0 and 88. Now in the group which stopped TZP, they gained weight, and there the weight loss was only 9.5%. So the answer is very clear. If you stop it, you go back. And why does it happen? It doesn't happen because you get dependent on TZP. It happens because there is a physiological basis and there is a neuroendocrinal adaptations, and the hunger hormones go up, and the satiety hormones like leptin and PYY and CCK, etc., start going down. And that's why you gain weight. Let's come to the adverse reactions. These are very common with all incretin-based therapies. So you have nausea, vomiting, and these are usually very common when you are increasing the dose, but settle down in most patients as they pass. Of course, individual variations are there. So they occurred during dose escalation and decreased over time. Now, percentage of participants who discontinued treatment, you can see here, was small. Even 15 milligrams, the discontinuation due to overall side effects was 6.2, and discontinuation due to only GI side effects was only 2.9. So I think reassurance in incretin-based therapies is the answer. You've got to really motivate and educate your patients. Now, why is there a difference between SURMOUNT-4 and because this was a withdrawal study. You only had patients who had tolerated 10 and 15 milligrams who continued the study. So therefore, the side effects that you see here are less, and again, of course, are GI, gastrointestinal in nature, and occurred during the escalation and decreased over time. Discontinuation rates again was as low as 1.8% due to adverse reactions in 15 milligram dose. Now, let me summarize for you. So we talked about 2 studies. First was the SURMOUNT-1, which significantly reduced body weight by an average of 16% with 5 milligram and 22.5% with 15 milligram. You had improvements in cardiometabolic risk factors, which means it's also a regulator of metabolic health. In addition to reducing weight, it reduced cardiometabolic risk factors like blood pressure, waist circumference, triglycerides, and improved HDL cholesterol. What happens if you discontinue? And I very clearly showed you that the weight goes back, and therefore uninterrupted therapy is probably essential to have a sustained benefit on weight. And the most common side effects, of course, were gastrointestinal in nature and were mostly mild or moderate, and they occurred during the dose escalation phase. Thank you very much.